Erin Morgan. She's our new tribal liaison with HCA. So I don't know, Erin, if you just want to say hi. Sorry, I didn't think about that before, but since I was just doing my land acknowledgement, if you want to just say hi to our team.
Yes, certainly. Hi, good morning, everyone. My name is Farron Morgan. I am the new tribal liaison here at the Medical Assistant Division. Welcome.
Thanks, Erin. So yeah, we're happy to have her here. So again, as we always start with these meetings, just to ground ourselves in the work of HCA and the Primary Care Council. This is the mission, vision, of goals of the HCA, or Healthcare Authority, and certainly is very much tied to many of the goals of the Primary Care Council. And this here is our Primary Care Council mission, vision, and goals as it stands today. Of course, we'll be talking a little bit about this in a little while in the coming quarterly meetings. But again, very much connected with the mission and goals of the Healthcare Authority here in New Mexico. And again, this was a slide Elise had done. I think it's really helpful because it pretty much sums up what this group has been tasked with for the Primary Care Council. Certainly, I think there's some areas we still need to work on, especially around the annual reporting to the legislative committees. I think that's all I've got for this. Zach, did you want to go through the agenda?
Yeah, so today's agenda, essentially, we're going to go over some key strategic goals and focus areas for the PCC. We have a great lineup of presentations, starting with Elisa Reed at 11, and then we're going to continue on with the New Mexico Rural Health Association with Caleb Blanchard. We have a presentation by Dr. Andazola, Primary Care is Foundational. And then we're going to have an overview of the Chili Chat with the New Mexico Department of Health. So we have an exciting lineup today. And then we'll go to the norms.
Can folks just mute themselves too? So we don't have any background noise. Thanks. So again, as everyone knows, this is also a kind of standard slide that we have for the Primary Care Council. Oops. Always does that. So again, this is for members of the primary care councils. As you probably saw from our agenda, we're trying to shorten up the primary care council a bit because it has been some very long meetings previously. But again, if you need to take breaks, go ahead and do so. We've got the chat function if anyone needs to put anything there, but you're also welcome to raise your hand and just go ahead and talk when called on. And that's our contact info. I think that's it. Oh, Maggie.
Good morning. I just want to clarify that the core members include the voting members as well as the non-voting members, or not the non-voting members?
Yes, member. Yes, both, Maggie. Sorry. We can clarify that on future slides.
Thank you.
Yeah, appreciate that. I don't know if we have Val. I think there was a number that might have joined. Let me just double check, but I think we might not have Val. As I said, she's being, I think, sworn in for her school board this morning. So I don't know, unless that's you, Val, on the phone. I don't think so. So yeah, we'll have to skip this, skip her remarks this morning.
All right, thanks for sharing, Tristan. the importance of the mission and vision of PCC. So before we dive into our presentation, I'm going to take a quick temperature check of the room for the PCC members, and I'm going to, share an anonymous poll with you right now. So just give me a second while I pull that up. So let me see, it says it's launching. Let me know if you have received a poll. Anyone? So you have about 30 seconds to respond. So basically, we're asking you, how familiar are you with the PCC's current activities? Very familiar, somewhat familiar, I know the basics, or, still figuring out. So I'm getting some responses, so it looks like it's working. So okay, so basically what I'm seeing is a mix of familiarity, which is actually really helpful for us to know. Let me see. So one reason why I actually wanted us to start here is because we only meet 4 times a year, and we want to be intentional about how we use that time. So I want to say this up front. Today is not about information overload. It's all about making sure everyone understands where PCC is, what's changing, and how you can engage in a way that makes sense for you. So let me just click down on this poll. So as I go through these slides, please feel free to raise your hand or use a chat. I'll do my best to answer now. Also have an amazing team here to help support the conversation. So one of the themes that you'll hear today is how we're creating more clarity and structure. So let's walk through what's getting improved. Okay, so the team here at HCA has been really working hard on figuring out ways to strengthen how PCC is structured, so we can move from setup into action. So our goal for this coming year includes driving innovation in primary care, developing and informing policy, supporting health technology, and strengthening workforce and payment strategies. The way that we get there is through some foundational updates. So finalizing our bylaws, updating our membership, creating a website, and then clarifying our meeting calendar, strengthening work groups, and really refresh our strategic plan. So I want to pause here and say that this might sound like a lot, but most of this work is already completed. What we're really doing now is organizing in a way that works better for all of you. So my role is to basically not reinvent PCC, but to really support you, connect you all with one another, and really help turn these ideas into actions. And one of the biggest milestones that I would say when I got onboarded here was that the bylaws were in its final form. So it's a huge milestone to share, is that the bylaws are completed. So please feel free to, raise your hand or drop a question in the chat if you have anything you'd like to share. So as I mentioned, the bylaws is, officially signed. So this is a major milestone. I want to thank everyone who took the time to review the drafts and, share feedback. Especially big kudos to Tristan and Val and Elisa for their leadership on this. These bylaws gives us clarity around the roles, expectations, and how decisions are being made, which is essential as PCC continues to grow. So our main ask today is for everyone to complete the membership form either today or sometime this week. So I put a QR code on the screen, and let me drop the link in the chat in case. Let's see, one second. So the purpose of this form is to really help us understand who is currently able to serve, in what capacity, and where interests aligns across these work groups. I want to be very clear, no decisions are being made today. this is all about understanding where everyone is at. And what I could do is sort of walk you all through the membership options. So there's going to be 4. The first one is going to be an active voting member. So those are the folks who are appointed, and they're going to be participating in formal PCC business, including motions and votes. Then we have our advisory members that contribute their expertise and participate in discussions and work groups, but they do not have a voting authority. If you would like to be just a general public, those are folks who are just members who would like to attend the PC meetings and provide public comment, but they're not appointed members and do not vote. Really just to stay informed and connected. Past members, if you select that option, that really would allow us to keep record of, if you decide to, if you take a step back from PCC, then, we'll note that. There's no wrong choice here. It's honestly just all honesty and, what works best for you. And if you select active voting or advisory members, you'll be asked to indicate a preferred term length. So that's either going to be 1, 2, or 3 years. So I recommend everyone to review the bylaws and fill out the membership form. The bylaws are available directly within that membership form. And then I'll also email them after this meeting. So as I said earlier, Tristan, Val, and myself are here to answer any questions that you might have regarding your membership. There might be one centered on like, what if I'm not sure if I'm a current member or not, So if you're unsure, please just go ahead and complete the membership form, or email Tristan, Val, or me, and, we'll follow up directly to confirm where things stand and, next steps. So if there are any immediate questions, feel free to unmute or raise your hand.
Hey, Zachary, this is Aaron Jacobs. Can you clarify, like on the form, it talks about the capacity. How do those correlate with the roles you just described?
So active voting members are those who participate, in voting. So if there's like a planning meeting where we're trying to discuss which topics to present on for the quarterly meeting, then that's when voting members would vote. And then also if they have the capacity to participate in subcommittees or work groups, then, that would be great. However, no formal, vote will be made until the actual quarterly meeting. So advisory members are just those that will participate in these work groups, subcommittees, and engage in these quarterly meetings. However, they just don't have a voting authority. So I'm not sure if that answered your question.
No, I mean a little bit. There's question 19. It talks about instead of listing it as voting member or advisory, it says stakeholder engagement and collaboration, leadership and planning, contributing subject matter expertise. So I just wondering if those.
Yeah, so that's a great question. That is just to help us understand what it is that you're interested in being part of the PCC. So it's just for our records. Once you join, we would like to see what you're interested in. It's not something we're specifically asking you to take charge in.
Okay, thanks.
Great question. Okay, so we are going to move on. Let's see. So I want to show you how we're supporting members between meetings. So we want to, let me see. We are currently working on a SharePoint website for PCC members. So the goal here is this to be like a one-stop shop. And I would really like to thank everyone who provided feedback during the PCC planning meeting. Your insight was extremely valuable in putting together the website. It is still currently getting developed, so we're hoping that this will be up and ready before the next quarterly meeting. But essentially, the SharePoint website will include meeting materials, a shared calendar, work group documents, contact information, and central repository for collaboration. So basically, it's just to make things easier. So information isn't siloed, and work groups can continue to collaborate effectively. One thing that I should note here is that the SharePoint website will only be accessible through the email you register on the membership form, which is why updating your membership matters. And for members of the general public, the HCA PCC page will still host the agendas, the slide deck, and the recordings. This is just like a one-stop shop for members who are part of the PCC. And since we are still in the development phase, if there are any feedback that you all might have, feel free to share. Just because, we want to make sure that this is something that will really help you all be engaged. So if there's anything that you've seen other councils or groups do well that we should consider, I'm here for ideas, some ideas. Okay, well, this is something that we're excited to, I guess, hopefully be finalized before our quarterly meeting. So let's move on. So along with the website, we're also clarifying how and when we meet. So as I mentioned earlier, the planning meeting met in December to discuss this quarterly meeting. And, we, decided to try and shift our times from 10 to 12 rather than 10 to 1 to focus more on these priorities. So with that, this is our 2026 Primary Care Council calendar. We're taking a more strategic approach to meeting for the quarterly meetings. We're going to continue to have these PCC meetings, but we're also going to be introducing an optional planning meeting 1 month prior. That purpose of the planning meeting is to review agenda items, identifying leads, defining outcomes, and really making sure everything aligns with our mission and vision. We've also created a clear agenda request process. So anyone can, submit topics for consideration. You would just, feel free to just reach out to Tristan and myself, where we could share with you the process. So this structure is really about making sure our quarterly meetings are, focused and, outcomes driven. So it really helps us from, move from discussions to deliverables. As always, revolutionize. So before I go on, does this meeting cadence feel like, it would help improve, our focus and follow through? I would love to hear from you all.
Thanks, John. John gave a thumbs up, which is just as effective.
Oh, awesome.
Yeah. Any
Yeah.
other feedback from folks?
I think this looks great, and I like the shorter meeting
Thanks.
length as well. Thank you.
Yay. Thanks, Jen. Thanks to Zach for all this work too. I think it just helps, right? So everyone has these dates. Everyone's very busy, so it'll be helpful going forward this next year so people can plan.
Yeah.
I saw some more thumbs up, so.
That's awesome. Thank you, guys. Yeah, so I'm not sure if the invites are sent just yet. So after this meeting, I will send an email with all these invitations for you to accept. So once you update your membership, then we'll, look and see what your email address is, and just to make sure we're sending it to the updated contact. All right, so with that structure in place, so let's talk about much of the work that actually happens, which is, let's see, let me see. All right, so this is where much of our work happens. Like I just said, our work groups. So now that our bylaws are finalized, we can better identify who has the, capacity to continue to participate and, identify which each, what each work group is responsible for. And really quick, by raise of hands, how many of you have joined a PCC work group so far? Awesome. That's great. Yeah, one thing that we really want to focus on in this new year is to really ensure members are fully informed about all the ongoing workgroup meetings. So this membership form lists all of these work groups, with information for each. So that QR code is still available for you to view. A short description for these work groups. At this time, a lot of you raise your hand. So if you're currently part of work group, I would like to hear, what's one thing that's been working really well for your group, and, how can we help support you strengthen your work group?
This is Jamie. I can speak to the GME expansion work group. I think that's worked well because we've had a very defined task and we have kind of a cyclical set of activities that need to get done, again, because it is connected to a particular task. One suggestion I have is the planning meetings that happen. I think it would be valuable if the chairperson or people from each of the work groups attend the planning meetings, so there's some connection across the work groups.
I agree with what Jamie said, that there needs to be some very specific designed tasks that the work group can work on, and I think that goes a long way. The other thing that I also think needs to happen is there needs to be an appointed chair or some sort of appointed leadership, because I think that helps drive the group, and then would be that member that would come to the planning committees as well.
That's great. Thank you, Dr. Anzola and Jamie. That input is really helpful, as we continue to think about strategic planning. We would like to have, clear actionable goals for each of these work groups. So it's really important that we have these discussions. So are there any other comments from anyone? I still see your hands up, Jessica or Jen. I'm not sure if it was just because of the previous exercise, but if you have anything to share, that would be great.
Jen, did you want to go ahead?
I guess we could move on to you, Jessica, if you have anything to share, and then we'll go to John.
Yeah, so I'm a part of the equity work group, and one thing that I really love about the equity work group, and was a recent discussion, is that the equity work group has many concepts and strategies and ideas and efforts and work to do in equity that really has a role with all work groups of the PCC. So we thought a little bit in recent months of maybe making a stronger connection of the equity work group with all other work groups in this effort. So I think that would be a really fantastic pathway for the work group to support other work groups.
Thank you, Jessica. John?
My recruiting efforts for the technology work group have been terrible, and I wish that I had a little bit of some social networking status to be able to get more people to help me. The SharePoint, I think, is going to help the technology work group because even if there's not that many members, I can kind of still kind of put ideas out and kind of work on things myself. So I'm hopeful about that. But I'm also kind of more willing to work with other groups too. So anybody that wants to help, I'm actively recruiting. So please go tell people. I know that doctors hate medical record systems and technology and billing systems. And I think there's a real opportunity for people to take some of those issues on directly with Medicaid through this group. So I would, just try to help me if you want to, anybody.
I just tried to recruit a part-time physician who had retired, and the first question was, do we have any HR? And I said, yes. And he said, not interested.
Thank you for that. All right, thank you guys for sharing your feedback. We have a tight agenda, so I'm gonna move on to the next slide. 1 second. So this is our strategic planning cycle. I'm sure you all are familiar with this. This is just another updated form that Tristan and I have worked on. So this isn't a finalized plan, but what we want is your input before our priorities are set. So I'm going to give everyone a quick minute to really think quietly about this and, see what your thoughts are. So like looking at this calendar, let's say like in 12 months from now, what would you like PCC to, completed, or what would success for PCC actually look like for you? Jen?
Thanks. I'm wondering if there's anything aside from residency expansion, just around workforce in general and number of PCPs or teams in primary care, some kind of volume metric. And really at the beginning of the primary care council, we talked about at least measuring Medicaid spending on primary care as one of the metrics and looking at, are we increasing that spend? Are we spending putting more of our money where our mouth is as far as primary care goes?
Thanks for sharing, Jen. I'm writing things down and I'll be following up with Tristan. Dr. Anizola?
Yeah, I just wanted to second what Jen said, specifically around the primary care spend. I wasn't part of the foundational original PCC group because I was the chair of the Graduate Medical Education Expansion Board. So I missed a lot of the stuff initially when the program was initiated. And John Helm really kind of gave me a clue of what that was like at last meeting about revolutionizing primary care in New Mexico. And I think that I really want us to take steps to do that revolutionizing. Primary care spend is one part of that. It's a huge part of that. And I'm going to mention that a little bit in my talk, but I can tell you that's why this legislation was initially put forward to think about the primary care spend. But I think primary care spend, even though it's kind of revolutionary, there's way more that can be done. I think Jen Phillips, John Helm, Matt Probst are all people who can speak to this and help move us in those directions. So really taking some of those ideas, making them actionable and well-defined, and taking steps to address those. That would tell me we've been successful. We've been successful. All right.
Awesome. Yeah, no, I completely agree because, we want PCC to really amplify primary care, support stakeholder communication and, when appropriate, inform policymakers and legislators. Matt?
Thanks. Yeah, same line there. And, just, kind of back to that history lesson of when it was definable, revolutionizing primary care into timely access to primary care for every New Mexican. And then timely, what does that mean? Within 24 hours. Wow, that's a revolution. And so I think that was like, wow, yeah, I'm all in. Here we are this far, down the line, and here I still am. But yeah, how we define that, and I think Jen brought it out, yes, obviously we need to spend more in primary care. And if we're spending it well, if we're spending more, that would mean we're moving a dial, but there's a chance we were not spending it well and it didn't really do anything. So I think that was the basics of something that was like low hanging fruit we could grab, and then realize that the dashboard was like, oh, that'll show us what workforce looks like. And here we are, getting the presentations on the dashboard, and the reality is that, if people aren't reporting, then the dashboard's not really it's not really helping us, right? And how do we get that to fix? And so going into this session, do we have to legislate or mandate, reporting? Do we work with, the other thing that was never really working that well, again, that's me as a member of New Mexico Healthcare Workforce Committee for so many years, that never really gave us the best picture or the full picture of the access part in terms of providers, and particularly primary care providers. So I think that's still where we are. And here we go into another session. So just back to your question of when we cycle back to this point next year, what would winning look like? Well, we all, we're making some movement, and again on that, is there a formal push from primary care council? Is there a legislative, one pager for the legislature that says, here's our asks, particularly for workforce, and, so that we can come back a year from now and say, well, did we get more funding for, loan for service repayment programs? Did we expand? Those types of things. I think those are some measurable actions within the next year that, at least until we should still keep pushing for some kind of a dashboard that measured, are we really moving the dial towards timely access to primary care for every New Mexican, or 24-hour access? But in the meantime, I think we all know that we need more. We're nowhere near that, and we need more, a lot more. And I think we have some actionable items and asks in this session. So a year from now, hopefully we're revisiting and saying, yes, we got those things. And I think just one other thing is maybe clarification, now that we know, for example, those that marked on the survey while I was driving over here from clinic, so I couldn't see, but it was mixed, just getting to learn. Well, to me, one of the first put money where our mouth is as a state was Rural Healthcare Delivery Fund. There was money, right? Now we're already the third round, right? 80 million, then 40 million, and now just another 20 million. That's $140 million. And has that $140 million moved the dial of increased access to primary care? So I think there's that question there. And how can we measure that? And then now we know we've got the rural transport RTP, right? The rural transport transformation program, that money coming out, and that federal money, and that 200 and whatever million this year, and hopefully $1 billion over 5 years in that plan. And within those 5 action items, workforce is a huge one. And so will that money move it? Finding out ways to tangible measure that, as we still just keep saying we need more and more and more and more, I think is still an ultimate goal. So I don't think we'll have that. We'll know in a year, but maybe we'll have a better plan of how we can, we can measure that.
Thank you, Matt, for sharing that.
I guess just
completely
in the
agree.
meantime, the best we can say is dollars.
Mhm.
Yeah.
Yeah, for sure. All right.
This is- Sorry, this
Maggie?
is Jamie.
Oh.
I don't know if these things are measurable or how they would be measurable, but I would like for us to have some concept of the scope of work of primary care in New Mexico. And I would encourage us to say behavioral health is primary care. OBG is primary care. So how many primary care doctors are treating behavioral health? How many primary care doctors are treating pregnant women and babies? We just looked at some Medicaid data as part of our SB3 planning, and they pulled behavioral health diagnosis, number of people in Medicaid with the behavioral health diagnosis, and the overwhelming majority of them had seen a primary care provider, not a behavioral health provider in the last year. So I just want to look at the scope of primary care and make sure that it includes that type of care as well. And there might be other types of care. Behavioral health is definitely one that I'm most familiar with, and also OB work.
Thank you, Jamie, for sharing that. Maggie?
I'd like to see I was saying I really agree with Jamie. And I'd like to see, I think we ought to see that there are multiple models of behavioral health integration. And there's challenges in terms of payment and in referrals and in documentation. But I think we need to take a look at that and undertake that, as Jamie said, to be able to give us some good information that we have to be flexible and operate in different arenas. And I think that that's a good place to start.
I agree. So, all right, before I pass it to Tristan, I want to open the floor for any other comments or feedback that folks might have on all the topics that we covered today. I really appreciate everyone's engagement and thoughtfulness. Like I said early on, that much of this work is already done. I'm just here piecing the puzzles together. So yeah, if there are any other questions or thoughts, please feel free to share. If not, we will go on to the next slide.
I wanted to say a couple of things. I saw that membership form. I filled out that membership form, I think, twice, and I probably filled it out different both times because I don't even know who I am. So, because I wasn't part of the original group, and I was chair, and then they said I was a voting member, but I wasn't sure I was a voting member. And so, if you see it multiple times and it's weird, it's because I don't know who I am, but I'd be willing to participate. So, or what my role is, if that makes any sense. I do know who I am. Number one. And then number two, I wanted to jump on what Jamie and Maggie have stated specifically with primary care. Quality primary care, I'm going to talk about it in a minute, is foundational. And really what I think is important is quality primary care, where the primary care doctor is prepared to deal with or not doctor, primary care provider is able to deal with what presents to the door, and it's many times behavioral health, and OBGYN, reproductive health care, all of that can be done under the auspices of primary care. And then the second piece of that puzzle is the primary care teams, building a team that's ready to do that. And that's really where the integrated behavioral health comes in, and adding those extra pieces of the puzzle that further support the mission. But you got to have that strong base, and you got to have that strong foundation. So I just wanted to say we really want to focus on that high quality provision of primary care and the training of the providers so they're skilled to do that. So I'm done.
Thank you, Michael. And then we're going to move on to Matt. And after Matt, we're going to go to the next slide because we have a tight agenda today. So Michael.
I was just wondering if you could email a list of current members and their roles. That may be a hard ask if no one really knows, but I know there's a statutory requirement for a member of the DOH, but I don't know if that's supposed to be a provider. I came into this before I was a member of the DOH, and now I'm a member of the DOH. But maybe if we could just get a current list of members and their current roles, I thought it might be helpful.
Yeah, I think that would be great. I'll follow up with Tristan and see what we can do.
Yeah, I think we can probably do some of that. I think also it's a mixed answer to your question is I think, right? Because with some of the, the PCC not meeting for quite a while, right? I think that's why me and Zach are really trying to figure this out. So again, it's a little unknown to us as well. So
and if it's easier just to scrap it and reapply from new, I get it. And just let me know that's what you're doing.
Yeah. So I think if you can just tell us your best, account of where you've been with the primary care council. I think me and Zach are just trying to kind of make a reset now that we officially have the bylaws approved, kind of set that baseline, because we've done similar with the Medicaid advisory, as far as ensuring we're meeting statute. And then obviously we can move forward with moving people from, either voting to advisory or vice versa. Or maybe just folks attending. So that was really the intent of this, is kind of just level setting for the council going forward.
Okay.
Yeah. Thanks, Michael. Matt?
I was going to ask that. And then also, I was listening on the car drive, but I came to the chat so I could do the survey thing, and I don't see it on here. So if you could email that too, because I wasn't able to access it earlier. And again, I understand if we can't go back in time and clarify everybody's roles, but I'll need that survey. There we go. Thank you. So that's that. And then I think John's point, just again, reiterating everybody's point here that, yeah, that was it. And even if we go back further to when, GME Council and then Primary Care Council were thoughts and then became potential legislation and then became law. That was it. And even the question on here, GME, to me, in my mind, always when I was, meeting and then advocating to make these laws, it was GME Council was all about the physician part. And then the Primary Care Council was going to be about the entire healthcare team. And so when you said primary care provider, and then we know behavioral health and CHW and the whole thing, right? Like, that to me, they're definitely all connected. So I think having a working definition, if we don't already, what is primary care? Because in our minds, we might say different things, but I definitely know I do behavioral health. I definitely know I do prenatal. I definitely know, Clint Brayfield that just finished his, fellowship as a family medicine resident after all these years of being a Senia de Salud and a dream maker in Las Vegas. He thinks of it as all of that. Right. What is that? And then what is the healthcare team? I think those are important things so that we're all working under the same framework.
Yes, I agree. This work that we're all doing directly supports not only HSA, but the state in general, the commitment to investing for tomorrow, and delivering today. So your expertise is really what makes that possible. So thank you all. We're going to move on to the next slide. Let's see, and I'll be turning it over to Tristan. Thank you, everyone.
Thanks, Zach. I know we're running a little bit behind, so I'm just going to keep this very brief because I'm sure many of you have seen already on the website that we've opened up the RFA for the next round of the GME grant for state fiscal year 26. Obviously, the grant itself has evolved with the help of the work group, kind of helping us see how we can, align some different strategies as we've been moving forward with that program. So that's what you'll see some differences there. We did have a webinar on Monday that was recorded that also has some more information. I am the procurement manager for this round. I'm learning. Yes, and Elise is here and will be supporting you with the historical content. But going forward, me and Zach will be moving forward with the work for that our RFA. So I'll just keep it brief unless anyone has specific questions, but you certainly can email me as well if you have questions related to the RFA. Again, I'll keep it brief, especially because I don't have a ton on the rural health transformation, but I'm sure you've all seen the articles on the award we got. So we're kind of one of the higher states for the awardees. I think we're 13th highest, which makes sense if you've looked at the way the application was done. Half of the funding was very much based on the size and rural frontierness of states. So to me, when you look at all the awardees, a lot of the funding amounts make a lot of sense. Again, we have 5 different initiatives that are included in the application if you've seen them. So a lot of focus on expanding access to care in communities, especially around chronic conditions and specialty care. There was also a fair amount about maternal health initiatives included in that initiative. We have another one specifically around workforce. So again, there's probably going to be quite a bit of work parallel with the workforce work group that John's helped lead. And specifically, if John hasn't seen it, there was a lot around K through 12 pathways for that initiative. So we'll be working on that. There will also be a Rural Health Innovation Fund, which is more of a competitive grant program that we're hoping that folks could approach similar to Senate Bill 3 as far as, seeing what communities need and developing applications based on what's driving the need in their communities. So that's the third one. We also will have some on like a health analytics platform. So again, right, we keep talking about these dashboards. Can we ever really get to one of those dashboards where you can get like real-time data that can inform the work and really is actionable data? So that's another one. And then the other one that to me, it just really kind of ties all of this together is what we're calling our Rural Health Sustainability and Innovation Center. So we're really hoping this center, one, can help us manage this very large grant, getting the funding out the door, because that's going to be the biggest issue, I think, for all states, right, is getting procurement and following all of that. But they also could provide technical assistance, training, any education, and really just supporting communities. Because I think, to me, at least as long as I've been in state government, I think lots of communities are well-intended and want to put these things in place in their community, but they don't even have the know-how of, writing a proposal or application or developing a financial plan or budget for that. So that's the other piece of that as well. So that's all I'll say about that. Of course, we have a website. We'll post more as we move forward with it, but I think we're like every other state. It's kind of fast and furious right now because we're already in the federal fiscal year for this $211 million. So.
Thank you, Tristan.
Yeah.
So now we're going to hear some organizational updates from HCA leadership. So I'll leave this to you, Keenan. I believe you're on the call. Okay, perfect.
Yep, I'm here. Thank you all for allowing me to speak. I hope you guys all had a great and restful holidays. Hopefully you got a little bit of time off to rest and recover before the madness that is the new year and the new session. For those that I haven't had the chance to meet, my name is Keenan Ryan. I am technically our Director of Pharmacy, and I am our Acting Chief Medical Officer. as our current chief medical officer is leading Medicaid in our director's absence. Pleasure to see you all. I used to be a PCC member up until I took a job here at the state. So next slide, please. Next slide. So we're going to talk about the preferred drug list briefly. I know I've presented this once before. We are pursuing a unified preferred drug list. Think of this as an abbreviated Medicaid formulary, not covering every item, but kind of covering your big ticket items for use. And what this will do, it'll standardize coverage between our fee-for-service unit and all 4 MCOs. So from now on, it will be the state in the position of authority to say, we think all members benefit from this agent, and that's why they should be on semaglutide versus tirzepatide, or vice versa. I'm just using that as an example. Previously, each MCO had the ability to determine which ones they wanted to cover and independently negotiated their own supplemental rebates. That caused some problems when you have people unable to transition between MCOs because they don't want to lose access to their coverage. It makes providers' life very difficult because it's not saying this is a Medicaid patient, they cover X. This is a Medicaid, whichever MCO, and it might be slightly different for each one. So this aligns there. It also includes our fee-for-service members, and I think one notable change from how we've approached fee-for-service in the past is we've been somewhat hands-off, largely because it's been a tribal members make up the vast majority, and there's been this, we didn't want to necessarily interfere with the choices of tribal members, which is a very valid and legitimate concern. However, these are New Mexicans, and if we're making a decision that this is the best therapy for all New Mexicans, it should be this is the best therapy for all New Mexicans. And that is why we're pursuing a unified, this is the same for everyone as we move forward. This also is something all 47 other states currently do, up to some manner, having a preferred drug list. We're really catching back up to where the rest of the nation is, and allows us to negotiate supplemental rebates. So it can really offset a lot of the driving cost. Quarter over quarter, we've been seeing 5, 10, sometimes even 20% increase in drug costs for our members. And this isn't the MCOs trying to get more money. This is cost of medications is increasing every day, and the price of therapy, whether it be, for example, in diabetes, first-line therapy now considers SGLT2s and GLP-1s, right? And those are much more expensive than, say, metformin. Not saying they aren't good agents. I'm just saying they're 1,000 times the cost. And so how do we make that work for our members? This is one way to do so. The other thing is by starting this system, it allows us to participate in some new and upcoming models that I'll talk about in the next couple of slides. But our first P&T meeting is scheduled for next Friday. Even though our preferred drug list won't kick off till the spring, probably in April, we'll do the first round of looking at some of the agents that we have to cover regardless. So things we don't put prior auths on, we're going to try and get those approved first because it's an easy lift for everyone, right? The MCO shouldn't have a prior auth on this, and neither should we. So we're just going to try and get those approved first and go from there. So if you want to come to a 4-hour meeting where we discuss medications, please, by all means, join our P&T. I see John shaking his head. But yes, please come on over, and we'll gladly welcome you into the discussion. Next slide, please. So the value that we have for this, I want to make sure that we're clear. And I'll go over this one a little quickly to try and catch you guys up on some time. Members don't have copays, and while HR 1, the new federal bill, did implement copays for encounters for like clinic visits, we do not have copays for medication and do not plan to. So the net impact to our members on this is 0. They still do not have a copay. There may be some initial abrasion when we get everyone over to the PDL, right? We've had 5 different plans. We're going to one plan. To say that it's perfect and it's going to be all wins with not some abrasion is not realistic. But what it will do in the long run is it allows members to switch. So if they were worried about what drugs they have access to. Now everyone has the same unified access. And so it shouldn't be, I can't leave MCO1 for MCO2 because we're worried about differences in formularies. We're setting the formularies. It also makes it easier for them to see what they have access to. There's one source of truth. The state website will have the preferred drug list, and they now know what they have access to, what they don't, and what it takes to get different agents. For our prescribers, I think it's a lot of the same benefit as well as an initial startup cost, right? There might be some PAs you have to do as the preferred drug list comes into place to make sure those already established members or these new members get onto the right agent. But from there, it's more simple or a simplified formulary where everyone knows what they have access to. And so in the long run, we think it really makes the provider burden better. But please just be patient with us over this next year as we move into this. Next slide, please. So what you guys have probably seen a couple different medication, CMI, which is the CMS's improvement innovation center. 2 models were released in the past 2 or 3 months, 2 weeks ago during the holiday break, relating to medications and kind of some most favored nation pricing, which has been floating around a lot these days. And so I just wanted to give you an update on these. The state is evaluating them. That doesn't mean we'll participate because a lot of the impact and the effectiveness of these models will depend on the contract the government negotiates with the manufacturers, and we won't know that till later this year. So we're interested, we're following along, anticipating, getting ready as if we would participate, but the ultimate decision hasn't been made. So I just want to set that clearly, but I did want to give you guys an update on what these 2 models are. Next slide, please. So the first one is generous. And so this is a model that looks where the federal government is going to negotiate pricing with manufacturers, and the pricing is pretty clear. They're going to take the most favored nation pricing between a group of G7 countries plus Denmark and I think it might be plus Denmark and Norway, and then adjust it for our GDP, and that's the price you pay. So a very upfront, clear calculation of most favored nation pricing. It might be cheaper in many instances. So while the cost is more upfront and simplified, the difference on this model is that the states no longer get control of coverage. Meaning, we used to be able to say, we want you to use this medication after you've tried this more cost-effective alternative. We want you to use this medication in accordance with the guideline X, Y, or Z. In this situation, we may not have the ability. We will likely just have to accept the terms that the manufacturer sets. So instead of them giving us a slightly higher cost, but we have more control of how we use it, they're giving us a lower cost and we have less control of how we use it. And that's the rub of the model, to oversimplify it. What agents are going to be included in this, the exact pricing has not been fully released yet because the government's actively negotiating these prices. I think this is a very innovative model and could be a long-term strategy for improving drug pricing. However, the effectiveness will be how effectively CMS can negotiate with manufacturers. Manufacturers do hold some of the leverage here because it's voluntary participation, and they may say we don't like these terms and just leave, right? And so it'll all see how that takes place. To participate in this model, we have to have that supplemental rebate system, preferred drug list system that we mentioned above. So even to participate in the future, this preferred drug list is really something we need to have in place already. In these slides, I gave the link to the model list down below. This is like a 5-year model, and we can enroll in it and may not participate the first year as we get our PDL up, and then choose to participate as it goes from there. Right, please. All right, this next one is balance. Now, balance specifically only applies to the GLP-1 agents, and specifically looking to use them for weight loss. Under Medicaid rules, coverage of weight loss is an optional benefit. I'm not here to say that I don't think decreasing obesity changes lives and improves health outcomes. The cost of these GLP-1s, though, sometimes becomes cost prohibitive. Some state Medicaid programs that have covered these have seen doubling in cost. And right now the average wholesale cost is $1,300 a month. They've seen a doubling of cost and utilization year over year, to the point at which they actually had to start decreasing their ability to cover these meds for weight loss. And that's been part of the reason why we've been hesitant to start it, is we don't want to start a benefit that we end up having to stop or turn down. And so trying to figure out what that is. And so this has been seen in North Carolina, Rhode Island, Pennsylvania have all seen this kind of runaway train of a cost. This model looks to improve that. This is, again, where the federal government will be negotiating drug prices, as well as looking to get the drug manufacturers to provide some lifestyle interventions. What that is remains to be seen. Is that an app on the phone? Is that a smart scale? Is that online nutritionist services? We don't know. That's still being determined and negotiated with the manufacturer, but look to do both a lifestyle and decrease in the cost of these medications. This one's a little different because you have to cover all meds in the model, meaning you don't choose one GLP that you want to cover, you cover them all. But it's interesting. We're still evaluating this one. Like I said, this was released December 22nd, so we haven't had a ton of time to really fully understand all the intricacies of it, but we're interested in it. And so these are our two models that we're looking at, and by next quarter, we'll probably have a better idea of where we stand with the next meeting. So I'll stop there from the pharmacy aspect if there's any questions on that before we move into Carl. Dr. Jacobs, please.
Thanks for this. This is super. Do you know when you expect the PDL to be in place?
Yeah, that's a great question. The first round of it will be approved, like I said, this next Friday. And then early spring, April, I would expect the start of agents to kick in. Now,
Yes.
go ahead.
Oh, go ahead.
We're not going to review every class in this because that would be like a 4-day meeting, not a 4-hour meeting. So it is going to kind of come in waves. So this first wave was there are laws in New Mexico that prevent prior authorizations and step therapy on behavioral health, substance use, autoimmune, and oncology. Those will be the classes we target first because that's the least amount of member abrasion. Because there should be there should be minimal PAs there in the first place. And then we'll move to some of these other agents. It also gives us time to see some of these models so that we can see if we want to just enroll in one of these models instead of implementing the PDL covering X and then have to switch it immediately for this model. So kind of a tiered approach, if that makes sense.
Yeah. Oh, I think this is really important. And then secondly, on the GLP-1s, do you know yet what the evidence is around combining that with lifestyle medicine or lifestyle medicine instead of, or to me, that seems like still the big question. And I don't know that there can't be that any real long-term data.
No, there's not.
And yeah, and then similarly, if there are long-term cost savings, how do you get people to care about long-term cost savings when people move? I guess in the Medicaid realm, if we're looking at it globally, if there may be enough time frame for which people are on Medicaid that it matters, but
yeah, you're exactly hitting one of the hardest points we have to do when we cover this model. GLP-1s are really expensive, but their long-term savings is really good. The problem with Medicaid is that those long-term savings occur when they're on Medicare. And we have to say, do we do that for Medicare? Which I hate having to sound like a money guy here, but it's like, do we do our housing assistance? Do we do our nutrition? Do we cover other medications, which also save lives, or do we cover GLP-1s, which save lives for people when they're no longer on Medicaid? And I hate having to sound like that, but that's the decision we get faced with just from a budget. For example, there's when we looked at if we covered this for every member, we're talking hundreds of millions of dollars at the current price. And so this model is very exciting because there is some data from ICER, which is the Institute for Clinical and Economic Review, something like that, that basically tells you your cost effectiveness ratio. Cost effectiveness of GLP-1s is about $700 based off current literature. If you get most favored nation pricing, you should start getting below that theoretically. And so excited to see what this comes. I don't want to oversell this. There have been other CMMI models we chose not to participate because it didn't look like it was actually going to meet the goals they were looking at.
Yeah. Well, the GLP-1s are costing lots of health plans.
Oh yeah, it's the hot button
employee-
issue of the year, of the decade, we'll say, for this. So I hear you. If this can change it, I actually think this is CMS's role of trying to get this started in Medicaid so that they aren't covering it all in Medicare. Will be
Thank you.
like, it covers both of them. I think that's the idea. All right. Comprehensive Addiction and Recovery Act. This is the stuff that has been all through the news for the past 6 months about mothers who are delivering babies with potential history of substance use, and how we implement this effectively across the board. Next slide, please. So I will give a shout out that we have a Deputy Chief Medical Officer, Jen Williams, who is a midwife by training, and she leads this project, and she is exceptional at this. So I'm giving the update, but if you have questions, I really want to get you in touch with her. She is leading this and has been kind of a rock star about getting this going. So there was a federal and New Mexico CARA passed in 2016 and 2019, and this we had built a structure that combined CYFD, DOH, and HCA about having care navigators in hospitals and having engagement with these individuals at this high-risk area. As you guys know, in last year's session, this was consolidated under Senate Bill 42, where a large number of the services were moved, not everything, to HCA. And so we have been working aggressively since that time to try and build work groups, understand the issues around this, the orders by the governor about implementing safe plans for every baby born. Has caused some wrinkles in this, and we're really working to make sure we are meeting our members where they are and understanding what's going on. We are actively working to make sure that we have expert training and basically trying to get to a point that anyone that sees a pregnant mother or a pregnant woman who has a history of substance abuse has the ability or is empowered to create a safe plan or a plan of safe care, and that will go through this unified care portal that we're actively procuring now. Next slide, please. And so the benefit of this system we're trying to do for the mothers, whereas we're trying to treat these underlying substance use disorders, everyone knows that that's really what we should be doing to make sure that it's not only safe for the child, but safe for the mother. Medications for opioid use are safe in pregnancy, although we run into this issue that I think I would love to throw out as a larger issue to the PCC, is that anyone that can prescribe a controlled substance should be able to prescribe medications for substance use disorder. When we look at the number of OB guys that are prescribing, minimal. When we look at the number of surgeons who prescribe a bunch of opioids post-surgery, minimal, right? And so it's still viewed, it's still practically being applied as a specialty issue. Like you need to be specialized in MLUD or substance use disorder to treat. It is moving into primary care. I don't know that it's fully there yet, but I would make an argument that it's not just primary care, it's everybody care. Like everyone who sees a person who could use this should be able to prescribe it, is my personal belief. I'm actually working to get my controlled substance license and do this myself. I think that's where we want to get with this as my side. moving forward with this is needed. You can see here in red that nearly 52% of pregnancy-related deaths were caused by overdose between 2015 and 2021. That has to change, and that's why we need this to be an everyone issue. Next slide, please. Why we want to get this for our babies is we know that if we can get them engaged in substance use treatment, then they're more likely to be engaged in care. Well child visits, more likely to just be involved and promotes better outcomes again for mother and baby. And so we're trying to create wraparound services that make sure they're all engaged and we can increase these outcomes for everyone involved. Next slide, please. I'm going to leave most of these here for your reference because I don't know that we want to get into the nitty gritty of the laws overall. So these next two slides, go to the next slide, please, are really the requirements from what was being done last year to what we're currently building to kick off by July this year. So the increase in responsibility and requirements for a variety of different issues. And so I will leave these next two slides for your substance or for your reference and go from there. Last slide, please. All right, so this was just the current directives that have been going on and provide some links for you in case you need it. On June 27th, 2025, we issued guidance to hospitals and birthing centers to provide guidance for all the following delivery exposures. So if they are exposed to fentanyl, methamphetamines, fetal alcohol, or polysubstances. There's a couple of different ways facilities can report. They can report to CYFD via the central statewide intake, or they can submit a plan of safe care through CARA. And that's why one of these, this portal we're trying to get is going to be huge because we can submit a plan of safe care through there. We do have a Falling Color portals, but we're expanding that, and the phone number for CYFD is below. I think that's my last slide. Are there any questions I can answer here?
Keenan, can you just clarify, is the Falling Colors is being replaced or being expanded? I thought it was
expanded. I think it might be a replace with everything we do, but we're expanding that unified portal system to be all encompassing, one source of truth for the CARA program.
Thanks.
All right, hearing nothing, I appreciate your guys' time. Feel free, I'll put my email in the chat. If you have any questions about any of this, feel free to reach out.
Right. Thank you for that update, Keenan. Right now, we're going to take a quick break. It's 11:20. We can reconvene at 11:25. I do want to be respectful of everyone's time, so we might run over the allotted time today. So if you're able to stay, then that would be greatly appreciated. But again, we will come back at 11:25 to go through our next presentations. So we'll take a break. Hi, Lisa. Mhm.
Hi, Zach. Nice to see you.
Nice to see you, and you being here again at the PCC. It's always great to see you on the call.
Every time, every time, like I know, like things are still moving, happening, and I see everyone. It just, I'm so thankful that everyone is stuck with us, through all of these different transitions and changes, and gaps in meetings, and I'm so excited that you and Tristan are leading the ship here and really going to continue this work with this group. I'm just so thankful, so excited. It's so good to see everyone's faces. Yeah.
Thank you for sharing that. I know it's always great to have you here, and we always welcome you to our meetings. So at this time, I'd like to hand it over to you, Elisa, and she'll be giving us an overview of the 2026 legislative session, and highlight any upcoming state and federal changes that may affect primary care. So the floor is yours, Lisa.
Great, thanks. Go ahead and go to the next slide. I can't believe it's legislative session again in a couple of weeks. It's the time just flies. Actually, legislation is being pre-filed as we speak, and there's already a big list of pre-filed bills. I'm happy to come back in a few months and do a deeper dive on kind of what's passed and what's come up, but we're just now getting bills loaded in from the legislature. There are some that I saw in there around nursing and some other things. So I've put the website here. If you all are interested in looking up what's being pre-filed, feel free to go to the New Mexico Legislature website, and you can peruse daily what's being loaded here before opening day on the 20th. So February 4th is the deadline for introducing any bills. Session ends February 19th. And then March 11th, legislation not acted upon by the governor is pocket vetoed. And May 20th is the effective date of legislation. So between now and May, lots of activity. All right, next slide. I also wanted to talk a little bit about some of the federal changes coming this year in 2026. I know you all are aware that HR1 made a lot of changes that we're now having to adapt to with our services. So for SNAP, the expanded SNAP work requirements are going into effect. We are doing everything we can to get that stood up, and the resources and technology and everything that we need to do to support folks in being successful with those work requirements so that they can continue to keep their SNAP benefits, and then supporting folks with their SNAP eligibility changes. We've created some posters for our customers. You can see a sample of that here. If you would like a poster for your clinic, let me know. I'll put my email in the chat as well at the end of this presentation. Let me know and I'll see what I can do about getting you at least the file for this if you want to print it up and put it in your office. We also have some upcoming changes to Medicaid that happen later this calendar year. And again, I'm happy to come back and talk more about these as they're being implemented. I know we're working really hard. Alex Castillo-Smith is working really hard with our agencies to get these implemented. So again, work requirements attached to some of the Medicaid payments, and then more frequent eligibility checks that we're gearing up for. And again, some narrowed eligibility. So we will have more communications as well coming out this calendar year. And so I'll make sure to communicate those with Zach and Tristan to make sure that they get communicated out to you all as well. So you can keep tabs on those changes happening. Next slide. Okay, some other federal changes are the Federal Affordability Fund changes. As you all know, that the federal government did not extend the Affordable Care Act premium tax credits. And so there was a press release that just went out, I think yesterday or the day before, from the governor announcing $17.3 million to help reduce premiums through June 30th for New Mexicans. But there's still more work we're hoping that happens in the federal landscape to help get those premiums, those tax credits reinstated. So we do have the governor in the governor's recommended budget, some additional funding that's proposed. We just got the LFC's recommendations on their budget yesterday. So I didn't have time to go through that in detail to give you an update on whether or not those are in there, because I haven't had a chance to look, but it was in the governor's recommendation to add some additional funding to continue these tax credits. And I think that's really all my slides, Zach, but I'm happy to answer questions, follow up with folks. Yes, people who will be disenrolled. I think we have that, but I don't have it at my fingertips. You mean for the Medicaid changes?
Yeah, for Medicaid, I see the 27,000 from the marketplace, but then
yeah,
there's a separate number for Medicaid, I thought.
There is, I just don't have it
Okay.
On that slide, but I can get that for you all and send it.
Thanks.
So you have it. Mm-hmm.
John, did you have a question?
I remember when Medicaid Affordable Care Act first started, I was working in a clinic and we were required to collect copays for the first, I don't know if it was like the first 6 months or the first year at the very beginning of the Medicaid expansion with the Affordable Care Act. And we were required, we were not allowed to bill for the entire portion of Medicaid unless we had that $5 copay. So I don't, is that part of the, I know you said that they're going to have the copay reevaluated until June or July, but is that part of the thing is they might just do away with the paying the copay and require people to pay it again?
So I'm not aware of that for Medicaid on the Medicaid side. These changes for the this is for the Affordable Care Act. So like Obamacare, our Be Well Marketplace changes. And so that's where those premiums are estimated to go up. They have gone up significantly as of December 31st. But I don't know if that affects the actual co-pays. It's more the premiums, I believe, that are changing. And again, I am not an expert on this, but I'm happy to do more research too, John, and see if I can find out some more information on that. I don't know if Keenan's on, maybe you have more insight on that since you're over at Medicaid. Any other questions? Jessica, I know food banks have been gearing up for some of these changes too. I don't know if maybe you want to talk a little bit about what you all are doing for the SNAP changes.
Yeah, thank you. Thank you for calling on that. I was just kind of actually formulating my question a little bit on this. So Roadrunner Food Bank of New Mexico is receiving inquiries and a lot of comments from those that we are serving, who are hearing that something might be happening with their SNAP changes. Certainly, we're hearing from donors and stakeholders and partners about it as well. I feel a little bit befuddled just because I've just come back from holidays. I'm not really quite sure who in our organization is really taking the lead on the communications, but I'm happy to find out. I think that those posters might be really helpful, right? And I do believe that in the communications that we're providing and interacting as we're interacting with community members, I definitely would want to strive to have good alignment with the communications with the healthcare authority on this, so that all these changes and their different timing and frames are being communicated in a way that's helpful and makes sense for folks. I can certainly say to you prior to the holidays that we are seeing vast increases in the number of folks attending food distribution or contacting Roadrunner Food Bank because they either have questions about SNAP or need some enrollment assistance. We have been discussing internally. I don't think we got too far on that with all the holidays and so forth, but we started thinking a little bit about is there a place for the national tool that just got rolled out through Find Help on SNAP and Medicaid and all those all the federal programs? It's a verification and eligibility tool. The tool also allows you to do your applications, those kinds of things. So we've wondered a little bit, would that be useful for Roadrunner Food Bank in some way? I don't know that we know the answer to that. We just learned about it in December, but that tool has gone live, right, at the end of December and across the nation. So that's another thing that we've been thinking a little bit about. Since I still have my holiday brain on, if you'll give me kind of some time to sort of figure out who's leading the communications and so forth, I'd be happy to get back to you, Lisa and this group. But we're seeing a lot of folks who are very concerned about SNAP. They're very concerned about Medicaid. And of course, we always have a subset of who we are serving that do not have insurance at all, and there's no connection to healthcare in any way. So I always maintain that when we're encountering that particular group, we do our best to help reorientate or reconnect individuals back to healthcare, particularly if they're letting us know I'm managing diabetes and all these kinds of things, and I don't have a PCP. We feel it is a role that's critical and a responsibility to help people connect to healthcare and finding their way to a PCP.
Thanks so much, Jessica. And I'm here if you want to connect with me and make sure that you're getting the communication that you need, the food banks need from us. I can just kind of connect those dots for folks.
Fantastic.
Great.
Thank you.
Yeah. Anything else anybody wants to talk about? I know, Zach, we're a little behind, so stick my email in the chat here for y'all.
Lisa, I don't know if there's anything on the ex parte renewals where you're using existing data to allow Medicaid renewals. Is that a thing?
I haven't been involved in that level of detail in these changes, but I can ask that question and get some more information on that.
Thank you.
All right, thank you, Lisa, for your presentation. We always welcome you to, come back and present an update. I'm sure that there'll be more questions to follow. But at this point,
inviting me.
Of course. But at this point, we're going to proceed with our next presenter. Kayla, are you on the call?
Yes, hello.
Wonderful. I'll leave it to you. Thank you.
Awesome. Thank you. Good morning, everyone. I'm Kayla Blanchard. I'm the policy coordinator for the New Mexico Rural Health Association. I just want to thank you for the opportunity to share a little bit about what we do. So in this presentation, I will share a brief overview of the NMRHA and then delve into the Rural Healthcare Task Force. Next slide, please. So starting off with our small but mighty team of 3, consisting of the Executive Director, Isela Garcia, our Board Chair, Dr. Carrie Schaefer, and myself, we work to carry out the vision and mission of the organization. Next slide, please. Now, in addition to our team of 3, we are supported by a diverse and dedicated board of directors that cover various disciplines and expertise ranging from community health workers to public health specialists to animal science. They are integral to guiding our efforts. Next slide, please. So the New Mexico Rural Health Association was founded in 2023 and serves as the state affiliate of the National Rural Health Association. We bring together organizations across sectors and disciplines to strengthen collaboration and improve health in rural and frontier communities throughout New Mexico. Next slide, please. So NMRHA takes an interdisciplinary approach to building and sustaining healthy rural communities, guided by the CDC's Global One Health Framework. And this framework recognizes that the health of people is deeply connected to the health of animals and the environment we all share, hence why we strive to diversify our operations like the makeup of our board. Next slide, please. Our vision is for rural and frontier communities across the state to be equitable and thriving, so we create space for interdisciplinary collaboration and innovative solutions that reflect the unique character and strengths of New Mexico. Next slide, please. All right, so now we're going to get into our key advocacy areas on the next slide, please. So in October 2023, NMRHA launched a statewide listening tour across the state. We engaged stakeholders from healthcare delivery, health equity, infrastructure, agriculture, social services, and community members invested in rural health. The goal of this listening tour was to build relationships with rural and frontier communities and use their input to shape the organization's priorities and direction during its first year. So as you can see in this word cloud, what some of the top and most common advocacy areas were amongst their respondents. So the rural healthcare priorities identified through our engagement reflect both the complexity and interconnectedness of health in rural New Mexico. Key focus areas include behavioral health, primary and acute care, workforce and labor challenges, and sustainable funding models that support both health and behavioral health services. Stakeholders also emphasize the need for access to specialty and ancillary care. And beyond the healthcare system itself, priorities extend to addressing the broader drivers of health, including poverty, early childhood services, food and nutrition access, environmental conditions, housing stability, workforce training and retention, and infrastructure. So in a nutshell, NMRHA advances this work through advocacy and education to elevate rural voices and drive informed community-centered solutions. Next slide. So building on the foundation established through the listening tour, we synthesized key insights and formed a task force to mobilize community partners around shared rural health priorities. Next slide, please. So the purpose of this task force is to identify and recommend policies that improve healthcare access, equity, and quality in rural and frontier New Mexico. To do this, we engage healthcare providers, nonprofits, associations, and community leaders to gather insights directly from the field. The task force committees are organized around the main themes identified in the listening tour results, ensuring that our work reflects the priorities of the communities we serve. We then develop recommendations that meet federal and state requirements and share them with the legislature, state agencies, and other decision makers. So along the way, we work to foster cross-sector collaboration that strengthens rural and frontier communities as a whole. Next slide, please. So our first committee is the Healthcare Access Committee, which focuses on expanding access to integrated health services, improving dental, vision, and nutritional access, strengthening the rural health workforce, and advancing culturally informed care. Next slide, please. So this committee approaches its work through a problem to action lens. Rural communities continue to face limited access to care, workforce shortages, and persistent barriers for uninsured and underinsured residents. So in this context, previous federal delays could slow technical assistance for the Rural Health Transformation Fund, while telehealth and community health workers are emerging as promising strategies to expand access. So looking ahead to the legislative session, the committee sees opportunities to advance interstate compact legislation and engage with federal and state programs like the Rural Health Transformation Fund and the New Mexico Rural Healthcare Delivery Fund. Our focus is on advocacy through letters of support, op-eds, and in-person engagement, while also monitoring funding streams to ensure rural priorities stay front and center. We aim to coordinate closely with partners, including the New Mexico Primary Care Council, federally qualified health centers, Indian Health Services, and other statewide stakeholders to support both the passage and effective implementation of these initiatives. So this is where this committee is concentrating its effort as the session quickly approaches. Next slide, please. Thank you. So for the Infrastructure Committee, key focus areas include strengthening broadband accessibility, telehealth and utilities, as well as transportation and housing. Next slide, please. So similar to the Healthcare Access Committee, the Infrastructure Committee is using a problem to action lens to address outdated traffic and pedestrian codes that leave vulnerable road users, especially in rural, frontier, and tribal communities at risk. Many codes haven't been updated in decades, limiting enforcement, even as telehealth and public health linkages highlight the importance of safe infrastructure. A major victory came from a committee member whose advocacy efforts led Albuquerque to update its traffic code. The revised ordinance now protects all crossings, extends protections to bicyclists and wheelchair users, and passed unanimously on November 8th, 2025, along with a public health education resolution. So looking ahead, the committee will be monitoring 3 key legislative priorities: a Senate bill on driver's education to increase training on interacting with vulnerable road users, funding allocation for automated speed enforcement so municipalities can reinvest more locally, and a careless driver / vulnerable road user statute to align state law with Albuquerque's updated protections. And so throughout, this committee aims to coordinate with legislators, the Department of Transportation, municipalities, public health partners, and academic institutions to ensure that rural and tribal communities' safety needs are prioritized. And now our Environmental and Agricultural Health Committee will focus on air and water contamination, radiation exposure, zoonotic diseases, as well as the health and safety of agricultural workers. Next slide, please. Thank you. So this committee is focused on the elevated health risks facing rural and agricultural workers and communities, including workplace injuries, environmental exposures, wildfire impacts, and limited access to healthcare. Those challenges are often intensified for immigrant and undocumented workers. So the broader context includes labor shortages and retention issues in agriculture and meat processing, pressures on water and soil quality from environmental events and data centers, ongoing wildfire and flooding impacts, as well as long-term health consequences from historical radiation exposures with limited pathways for compensation. So some key policy opportunities we've discussed
included advancing worker safety initiatives, strengthening water quality and environmental oversight, expanding protections and health supports related to wildfire exposure, and supporting rural school-based health centers. In action, the committee is discussing a first aid kit distribution pilot initiative to improve worker safety, conducting research on water quality, wildfire health impacts, as well as reviewing relevant legislation to guide advocacy during the session. Next slide, please. Now, here are the other two committees in the task force: structural racism and discrimination, as well as a data and evaluation committee. They have not begun due to no signups yet. However, if you are interested in joining, or you know someone who would be a good fit for these committees, please feel free to reach out to me. Next slide. Now, this slide is blank because our work is ongoing. The committees are still meeting and planning to meet before the session begins, but we are reviewing pre-filed bills and deciding which legislation to monitor as it trickles in. Next steps will be guided by those discussions as we continue to refine priorities, coordinate across committees, and prepare to take action to advance rural and frontier health in New Mexico. Next slide. Thank you all for listening. Please feel free to reach out to me. We have our committees, but we also meet on a quarterly basis as a large group with the task force. And our next quarterly meeting is going to be March 17th at 10:30 to 12. So again, feel free to email me if you have any questions or if you would like to join our team. And I will hold for questions if there are any. I'm not hearing any, but if a question does come up at a later time, feel free to talk to me and I'll get an answer to you as soon as possible. And thank you again for this opportunity to share what we do.
Thank you so much, Kayla. I really appreciate this presentation. It definitely aligns with, PCC's focus on rural access and equity. I'm sure a lot of folks are going to be attending the next meeting. So I'm sure you'll also get into some couple of emails. But if there's anything that we receive on our end, we'll follow up with you. So thank you. All right, at this time, we are going to move on to our next presentation by Dr. Enzo.
Hi, everyone. Go ahead and go to the next slide. I was asked to do a presentation about primary care by Val, and I think I was kind of confused about what she wanted per se. I know she's not here, but I really think it's based on what this Yogi Berra slide is about. If you don't know where you're going, you'll end up someplace else. To me, it's about direction, right? Where are we going? Where do we need to end up? What are we looking for? And I think I want to talk about who we are as a primary care council, kind of from a foundational standpoint, because there are so many things happening in medical care, in the care of our communities, that I think has distracted us somewhat. And I think we really need to refocus on strengthening primary care for New Mexico and then build off of that. So let me go through some of the data that exists. And this is the stuff I talk about all the time. So you guys have heard this. So go to the next slide. So high quality primary care is the foundation of a high functioning healthcare system. I took this from Implementing High Quality Primary Care, published by the, I always get this. It used to be the Institutes of Medicine, and now it's the Academies of Science and Medicine in 2021. And they reviewed, the world literature, both data from the United States and other countries all across the world. and they found that primary care is essential to achieving what they call the quadruple aim. We used to talk about the triple aim, and now we talk about the quadruple aim. And what is that? It's a better patient experience. And what that means is not only how the patient is received and what happens in that clinical appointment, but it's also the quality of care they receive. When they get their care, they're less likely to be harmed. They're more likely to leave the appointment a better person. The second one is improved population health. We're talking about the health of populations. The third one is lower costs. That's the triple aim, right? Better patient care, improved health population, lower cost. And then they added this fourth bullet point, which is a healthier, more sustainable workforce, because the workforce also needs to be less likely to suffer from burnout, less likely to leave the profession, less likely to leave the state. And so we got to think about, when we're building primary care, are we doing these things? So go to the next slide. More data shows that primary care is unique. It's the only part of the healthcare system where increasing supply is consistently associated with better population health and more equitable outcomes. Increasing specialty care does not show the same effect. And there's some studies that are really interesting. It compares primary care to oncology, primary care to cardiology, primary care to gastroenterology, and it goes through the specialties. And the only specialty that has been shown to improve population health and health equity is actually a strong primary care base. And for this reason, primary care functions as a common good, making its strength a quality of public concern, not just a market issue. So this is why House Bill 67 was passed. That's why the Primary Care Council was founded. We were founded really to strengthen primary care because it's a common good for our communities. It's a common good for our state. And it's not just a market plan. So I think that's important. So go to the next slide. All right. So higher rates of primary care physicians show better health outcomes, lower mortality from heart disease, cancer, and stroke, longer life expectancy, lower all-cause mortality, lower maternal and neonatal and infant mortality, improved mental health outcomes, even after adjusting for socioeconomic and socio-demographic and lifestyle factors. That's crazy, right? So if you are wealthy and doing well, if you have primary care in your community, you do better. If you're poor and struggling and you have primary care in your community, you do better. So primary care improves your outcomes regardless of your socioeconomic and geographic and lifestyle modifications. This data has been reproduced time and time and time again. In fact, the Academies of Science say they don't even want to talk about or defend this idea because we know it. We know it to be true. Barbara Starfield is one of the big advocates of this and has written a lot of papers and did a lot of studies. She was a pediatrician and did a lot of study out of Johns Hopkins and really did international data and really published a lot of the main topics that we talk about this. The reason I'm bringing her up is because I presented some of this data recently, and this man came up to me here in Las Cruces and he goes, yeah, my mom used to write a lot of this stuff. And I go, like, who's your mom? And he's like, Barbara Starfield. I'm like, dude, you're like a hero of mine. I love you. I don't even know who he was, but Barbara Starfield used to live in Las Cruces. Just wanted to throw that out there that she spent some time doing this, but nonetheless, these things are important. And so I think it's really important to really focus our attention on the foundation of primary care. Show me the next slide, please. All right. Not only does primary care improve your health, it reduces cost. Fewer hospitalizations, fewer avoidable admissions, reduced emergency department utilization. There's really good data on this. So we're talking about making our dollars stretch. How do we make our dollars stretch? Improve primary care. I think that's really important. Go to the next slide, please. All right. And when primary care is lacking, we know that minor problems become chronic conditions. We have more emergency department. And this is the flip side of the coin from the last slide. More emergency department utilization, Preventive care declines, overall healthcare costs increase. And this doesn't matter what community you're serving. Without primary care, your cost of care increases. And go to the next slide, please. All right. This is back to health equity. We know that strong primary care improves health equity, is linked to more equitable access to care, reduced disparities in healthcare outcomes across populations. International as well as local state comparisons consistently showing that countries with stronger primary care orientation have lower all-cause mortality and lower premature mortality, and fewer healthcare disparities. All right, so I've been on this soapbox. It's my favorite soapbox, as you guys know, but I've been on the soapbox for a minute. Let's go to the next slide, please. But this is what the United States does. Go to the next one. So this is from Milbank. This is from, oh my God, I want to say 2021, but these are healthcare expenditures in the United States. So the orange bars are volume of individuals who are seeking medical care, and the green bars are expenditures. You can see the far right, hospital inpatient, 3% of the population seek care from a hospital in an inpatient setting, yet 26% of the healthcare funding goes to hospitals. Specialty care and primary care, about the same amount of people seek care from both of those, right? 35% go to primary care, 35% go to specialty care. Look at how much is spent on specialty care versus primary care, 5%. Nationwide, the healthcare spend on primary care is between 3 and 6%. 3 and 6%. So every dollar spent in healthcare in the United States, 3 pennies is spent in primary care. But we know by mountains of data that I just went and told you guys about, is that you have better health outcomes, you have lower expenditures, you have healthier populations, people live longer, you're less likely to have a heart attack, stroke, your babies are healthier, your moms are healthier, on and on and on, but we don't spend the money on primary care as we should. Rhode Island recently passed a law where they doubled their healthcare spend. They went from 5% to 10%, and they legislated that. And they've been able to monitor and measure improved health outcomes. So I think this is really, I'm trying to lay a foundation and seed and some ideas for our responsibility as the primary care council and the next steps that we need to take to address health in New Mexico. And by addressing health in New Mexico is really strengthening the foundation of primary care. Go to the next slide. These next slides are my favorite topic as well, is about people entering primary care. So these are, the orange line are medical students entering a specialty training. And you can see the orange line continues to go up, even though the blue line is which is primary care residents, goes up. It has plateaued and continues to struggle. More residents, more medical students are interested in subspecialty care than they are in primary care. And this is true for PAs. This is true for nurse practitioners. We need to make this specialty, regardless of licensure, the most important specialty. And we have to increase the spend and the support of people entering primary care, regardless if you're a nurse practitioner or an MD or a DO or a PA, that the foundation of care should be primary care. And go to the next slide. So this is also a very similar slide. The orange bars, well, the blue bars are primary care in total, and the orange bars is if you remove hospitalists from primary care. And you can see about it's 19.8% in 2022, 19.8% of individuals who were primary care trained, this is actually physicians who are primary care trained, actually went into primary care. Or the people graduating medical school, only 19.8% actually went into primary care. Even though 24.4% were primary care graduates, that little extra piece were actually hospitalists. And so we lost people on the ground practicing primary care, and we continue to lose that. So there's not people in the clinics providing full spectrum primary care. We're going other places. One more slide. All right, this is from New Mexico, and this is also from the Milbank. And this is interesting. This is primary care residents trained in rural and underserved areas. You know, New Mexico has always been a leader, and recently we've decreased. And the red line is New Mexico, and we continue to decrease, where the national trend is about 65% of individuals are training. Primary care residents are training in rural underserved communities. New Mexico has dropped to less than 50%, and the trend continues to drop both nationally and for New Mexico. That needs to be reversed. We need to get people in primary care settings. We need to get them experience to primary care training. And we need to take on the challenge. I know there's been challenges in rural training, but there's also been successes in rural training. And I think we need to continue to strengthen and support training in rural communities so physicians will practice there. Next slide. This is money spent. This is really interesting. In New York, $15.5 million is spent. Oh my God, how is that? Is as percentage of people entering? Well, $15.8 million is spent in GME payments per 100,000 population in New York. So if you have 100,000 people in New York, there's $15.5 million spent on training physicians in New York. But guess where all their training is spent? Their training is spent primarily on subspecialty training. Only 15% of people are actually being trained in New York on primary care. The Atlantic Northeast and Northeast part of the United States has the highest percentage of GME funding in the entire country, and the vast majority of that goes to subspecialty care. Harvard doesn't even have a family medicine department. If you look at North Dakota, they get $2.1 million per 100,000 people, but 43% of their trainees are entering primary care. New Mexico, we get the same amount, $2.1 million per 100,000 people, where 28% of our graduates are entering primary care. We can do better. Next slide. So, you know, this is from the Institute of Medicine that was published in 1996, talking about primary care, America's health in a new era. It talked about how primary care is essential to maintaining health care in New Mexico. And go to the next slide. That was in 1996. This next one is implementing high quality primary care, which I talk about frequently, was published in 2021, now by the National Academies of Science and Medicine. Also saying the cornerstone for healthcare in the future of this country, if it's going to be successful, should be primary care. That means we should fund it. That means we should train people in that. Go to the next slide. It talks about very specific steps. Go to the next slide. Number one is pay for primary care teams to care for people, not doctors to deliver services. And I think this is really important because we pay doctors to deliver services, right? How many patients did you see? No, don't go back. Don't put that one up yet. And it's talking about funding primary care teams. This is our integrated behavioral health. This is our community health workers. This is an entire team being paid to provide primary care, not just on volume. This is the revolution that we talk about. This is the concerns that we talk about. And how do we do it? I don't know. I don't know how to do it, but I think we need to try something. And I think that's important. This is based on data, based on science. We can do this. Next. Ensuring high quality primary care is available to every individual and every family in every community. This is a focus back on, we got to get out into our rural communities. We got to make sure that everybody has that access. Next slide, next, whatever. We need to train primary care teams where people live and work. That's really important. We're training primary care teams in ivory towers. We need to get them out of the ivory towers. We need to get them into the communities where people live and work so they know the communities so they can provide better care. Next slide. We need to design information technology that serves the patient, family, and interprofessional care team. this is really important. Today, we are moving in a place where technology can service on multiple levels. They can take burdens off of our plates. Where ambient AI is doing that, and this allows providers to provide care and allows the ambient AI to do the documentation. We can use technology that gives us the data that we need. Like Matt was talking about, we have these programs, but nobody utilizes them. We have to utilize them. We have to see the data. We have to understand what our next steps are in implementation of this. Next slide, please. And the last step is we need to ensure that high quality primary care is implemented in the United States. These are the 5 implementation steps from the implementing high quality primary care. I can tell you, number 1, we need to focus on number 1, and we need to focus on number 3. I think those are 2 steps that New Mexico can take today to ensure that primary care is actually in our rural and underserved communities, that every physician, every patient in New Mexico has access to high quality primary care. Next slide. So this is my last slide. And I said that this is not aspirational. This is not. These things can be done. And I think we need to do it. This is the most consistent finding in the literature. My soapbox that I always jump on is when primary care is strong, systems perform better. We save money, people are healthier. There is much to be gained by a strong primary care workforce. When it's weak, the system pays for it. And I have seen that in my community, and I'm seeing that in other parts of the state. So I really wanted to really leave everybody with some foundational material. I can provide references for you. In fact, I think I have a white paper that I've created that has all of the references available that we can look back and you can refer to. But what's really important is I think setting a vision, setting a direction for us as a group when we're going to go forward, what our next steps is and what we need to do. So I hope that's what you wanted, Zach and Kristen and the leadership. And I'd love to hear any feedback or thoughts that anybody has on that.
All right, Billy?
John, I would love the white paper to be maybe shared with the whole group. That'd be awesome.
I
With all
will
the
do that.
references.
I will do that. There's some tweaks so I have to make in the white paper regarding loan repayment, and I can talk to the group about that as well. Mac, I saw that you had your hand up and I was muted, giving you permission to speak. Sorry.
Me?
Mac Bowen,
Oh,
but I
Mac
think
Bowen.
and I think he's muted. I think you're muted or his microphone's not working.
Or you can put it in the chat, Mac. We could try with Jessica and then go back to Matt.
Yeah, he's on a work computer. Jessica?
Yeah, thank you, Dr. Antisola, for this presentation. I personally always love when you speak about this. It is re-energizing. I know that I had shared in connection with the some of the advocacy and the policy and the things like that around SNAP and Medicaid, that Roadrunner Food Bank is always trying to do its best to help reconnect folks to primary care. But I'm wondering a little bit, what role could Roadrunner Food Bank or any community-based organization or nonprofit organization have to help lift up the messaging, the communications, the advocacy, not only with the community, but with legislators and stakeholders about the very critical, really important role of primary care? What can we do to help? That's something I'm always kind of wondering, because it's a place that I would love for us to help.
No, absolutely. I mean, I think there's a couple of places. I think number one is just reminding our legislators, our team members, and whoever you speak to, whatever forums, of the importance of primary care. And I think I have talked to members of the HCA, the New Mexico Primary Care Association, and others about us creating a statewide advocacy platform for primary care. You know, just reminding the state how important primary care is, and that needs to be supported, et cetera. I think our medical students need to be reminded. I think our legislators need to be reminded, but I also think the general public needs to be reminded. You know, and I run into people all the time and they're like, "Oh, you're a doctor, great. What kind of doctor are you?" And I said, "I'm a family doctor." And they're like, "Oh, you're just a family doctor." And I'm like, "Dude, like I'm the most important, you know? Yeah, let me tell you about primary care." So I want to change that. I want to change that vision. Um, I think that's part of it. I think the other part of it, Jessica, and I think it's part of what we talked about, is, you know, implementing primary care teams. You know, I would love to the team to include the food bank, and you know, moving towards ideas of healthy diets and food prescriptions, and, you know, other ideas where we build teams around health. And I think, you know, so joining the table and being part of that, I think is valuable. And I hope that's helpful.
It is, and it just reminded me that prior to the holidays, there was the meeting with Project Echo, discussing care coordination, and I brought the topic up during that meeting, and there was some interest in exploring having community-based organizations a part of even care teams, care coordination kinds of teams, which I would absolutely love to explore. So you can certainly mark me down for if there is a statewide advocacy platform. There is some exploration for care teams that I am highly interested to be engaged with that. And I think the last thing I'll say here is that I think what we could do at Roadrunner is maybe document a little bit of our strategies or processes and how we're trying to reconnect folks to primary care, and the messaging that we're carrying forward about the absolute importance of primary care, so that you can see a little bit of what we're doing, and maybe even maybe this council can give us, you know, even a little bit of some guidance or direction where we can strengthen things or improve things, you know, in that messaging and communication. So I'm happy to work on that.
Awesome. I'll definitely keep you in mind as things move forward. Absolutely.
Terrific.
Maggie?
Yes, as I was listening to this, what kept coming to my mind is a campaign. And so maybe this group can establish a network of providers, of stakeholders, and develop a campaign that is not going to be short-lived, but it's going to be long-term. I'm sure there would be some money available to support something like that, but I would really, that would be really phenomenal for this group to do, is to really establish it and engage all kinds of providers in supporting it. And I'm thinking of specialty providers, how they need to also be brought to the table and engaged in supporting primary care.
No, absolutely. And I think that's part of the white paper too. Did I put that in the white paper, Zach? Something about promoting or being an advocate, advocating for primary care on an ongoing basis.
Yes, I believe so. To double check on that.
Yeah, I
wrote it.
believe you did, John.
I don't even remember what I wrote.
Yeah. I mean, I think we could certainly expand it, elaborate, you know.
Absolutely.
But you did.
Yeah. And so, Maggie, thank you for that, because I think it is absolutely what we need to do. I think people need to hear about it over and over and over again. They need to understand that that primary care truly is foundational for health in our community, and we need to lay that foundation to make it strong. Jennifer Phillips, do you have anything to say? Because I always want to hear from you.
You're so sweet. Thank you. I would just say, preach it, brother. That is, I just was like loving it.
Okay, sounds good.
Right.
And it's
Thank
Happy
you.
New Year, and I'm excited to keep doing this work with everybody. Hopefully for
Mhm.
another 5, 10 years, 15 years, 20 years.
Yeah. Yeah, thank you, Dr. Anzola. I always enjoy hearing you speak as well. I think it's really important for all of us to have like, that shared definition to really help us, align our recommendations, policy proposals, and, just really help, with the work group goals. So we all speak from the same understanding. So we're really grateful for you. You call it a soapbox. I call it innovative, ideas and strategies strengthening primary care. So what we're going to do now is we're going to move on to the PCC next steps. And to get us started with an announcement, we're going to have the New Mexico Health Communications Hub do a brief presentation. And I believe Deanna is on.
Yes.
Wonderful.
Hi, everyone. I promise I'll be 2 minutes and 40 seconds of your time. I know because I timed myself. Thank you so much for everything. I'm Deanna Bryan. I'm the Community Project Manager for the New Mexico Department of Health's new communication hub called Chili Chat. I'm here very briefly today to invite your members to participate and share the information about our upcoming pilot. If you want to go to the next slide for me. So Chili Chat began as a concept introduced by Dr. Anjali Taneja in collaboration with NMDOH leadership and grew out of needs highlighted during COVID, specifically the need for more direct, ongoing communication with public health and a way to reduce isolation among providers across the state. So at its core, Chili Chat is credential gated, a professional online community for primary care and behavioral health and frontline health workers across New Mexico. And the goals are to strengthen collaboration between providers and NMDOH, improve access to timely guidance, protocols, and best practices, and reduce isolation and improve coordination for both routine work and also public health emergencies. You can skip ahead 2 slides now, actually. So within the last year, we used provider input to help shape our community structure and approach to organizing content. And now we are entering the next phase of provider input, which is our pilot phase. And this is where we're hoping that the PCC can help participate and spread the word. So we are inviting verified New Mexico providers to participate in this pilot testing, and it includes primary care providers, behavioral health care providers, rural providers and clinic administrators, CHWs, SWs and CHRs, nurses and other frontline workers, as well as any others involved in care coordination, referrals, or Medicaid billing. You can go to the next slide for me. The pilot experience is intentionally structured, but very flexible and designed for providers with varying levels of comfort with technology. And participants can take part in phase 1 or phase 2 or both, depending on their availability. If you want to skip to the next slide, that has a little bit more details. Each phase runs for about 4 weeks, but the time commitment is broken into very small manageable activities, including things like a brief user experience survey at the beginning and end of the phase, free flow, real world exploration of the platform at your own pace, and 1 virtual 45 to 60 minute usability session scheduled at a convenient time for everybody. So phase 1 pilot testing begins in late March of 26, and phase 1 signups will close on February 27th. We're also exploring pilot incentives, and when we have more details about that, I'll share those out as soon as we can. So as you see in between each phase, we're going to have some type of data analysis. That's going to be around 3 weeks. We're going to take the feedback from each pilot phase and use that feedback to improve the hub. If you want to go to the next slide for me. So you can skip ahead to the end. If this sounds useful, or if you know of providers who feel like they're piecing information together across multiple systems, I have a hard time navigating that NMDOH website to find content that they need, or just need a little bit more of connection and clinical guidance from their peers, we would really value your voice in shaping this resource before our statewide launch in September of 26. So you can use that QR code here. You can go to tinyurl.com/ChiliChatPilot. And I'm happy to follow up directly or answer any questions you have now. And if you, I'll send this in the.
Oh no, I think you got muted.
You're muted, yeah.
Yeah.
I don't know how that happened. I'm so sorry.
It's okay.
It said you need to let these people go. So I just put the PDF in the chat. Hopefully you can view it. And on the very last slide, there should be some pictures of everyone on my immediate team, as long as their emails if you have any questions. But knowing that it's 2:26 my time, I live in Georgia, I will stop talking and open it up for any questions you may have about the pilot testing or ChiliChat in general. And thank you so much for your time.
Thank you, Deanna. I know that this is one of the flyers that we're going to be sharing out with all the PCC members. I'm sure once everyone reads it more into it, you're probably going to get a lot of signups. The PCC is really engaged with a lot of the forms that are sent. So, just something to expect.
Thank you so much.
Mm-hmm. All right, so and this is her team. They're amazing at the DOH. So I will send this. This slide will be available on the PCC website. So if you would like to learn more and how to reach out to, just follow up. All right, we made it, y'all. Thank you, everyone, for your time and engagement today. I know we went over our time, and that's a good sign. It really shows that we're engaged and, invested in all of our work in strengthening primary care. We covered a lot of ground today, from memberships, bylaws to work groups. And your input today is really critical to help us move forward. So I'm going to open up the floor before we convene.
I'm just going to say thank you to Zach. I appreciate you and all your hard work. I think, like I told him, he messaged me we were running late, and I think it's a positive that, I feel like the PCC, there's just a lot more renewed energy moving forward, and he's doing an excellent job. So I just want to give my gratitude to him and John as well, and everyone, all the other presenters.
I second that, Zach. You've been great being part of this, and I think we're definitely re-energized. So thanks for all your hard work.
Thank you all for being part of this conversation. And, this discussion in general. The PCC is in a strong position to drive meaningful change in New Mexico, and it's because of your expertise and collaboration. So, we'll keep you updated on the next steps and follow-ups, and I look forward to continuing this work together. Tristan and I are available if you need anything. But yeah, other than that, thank you for everything you do for primary care and our communities.
Thanks, everyone.